Good afternoon or evening to everyone. As Nikki says, I'm Sanale, and I'm from the UNICEF East Asia Pacific Regional Office Nutrition Team. So I'm really delighted today to be sharing a snapshot of the findings from a multi-country study that reviewed current healthcare system practices in the care of nutritionally at-risk mothers and infants under 6 months. So as Nikki said, the study was done in 4 countries in East Asia: Cambodia, Vietnam, Indonesia, and the Philippines. Next slide, please. Next slide, please. Yes. So why focus on infants under 6 months? Really, the focus was really because of the fact that this age group is often overlooked when it comes to understanding the nutrition needs. Many infants are small, as we know, and at risk of not getting enough nutrition. And it has recently come to light in recent years that the global burden of at-risk infants is quite high. We don't have enough information about the programs to help these infants and their mothers, and there's not been clear guidance in the past on how to identify and treat them. Current policies don't often consider how the well-being of the baby or the infant is connected to their mother. Yet, as we know, that the strong body of evidence clearly shows that link. Next slide, please. So with that background, the aim of this multi-country study was to understand and describe the current healthcare practices for caring for nutritionally at-risk infants and women, both pregnant and lactating, in 4 countries in East Asia. We used the MAMI framework approach, whose main components are shown on the screen, to contextualize the approach to data collection and the development of tools for data collection in the 4 countries. Next slide, please. So these were the definitions of nutritionally at risk that we used in the study for the 3 population groups: the infants under 6 months, their mothers, and pregnant women. These do align with the criteria used in the MAMI framework to describe the nutritional risks of these 3 groups. Next slide, please. So in terms of the methods that we used, we first of all employed 2 phases to data collection. In the first phase, we did a desktop scoping review, which involved looking through relevant publications, guidelines, and policies for the identification and management of nutritionally vulnerable infants and their mothers. The documents that needed to be translated were translated by local experts, and we basically included all the documents that were relevant to the study, so we didn't have a limit to the number. The analysis, and I should note that the analysis did not initially include the at-risk pregnant women group. However, subsequent phases with the data collection, with interviews and policymakers, we did include pregnant women. On your screen, you can also see that in the green, I'm sorry, not the green, the orange, there is a standardized tool that we use to extract data from all the shared government policy documents, guidelines, and any reports that we got. And this was, again, based on the MAMI the MAMI framework's main components. Next slide, please. So the second phase of the study, basically groups of frontline health workers were interviewed remotely by telephone by the local consultant who was recruited by the researcher. And the aim of these interviews was to assess if and how nutritionally at-risk women, at-risk infants and women rather, were identified and managed by frontline health workers at different levels of the healthcare system. So that was the healthcare worker interviews. And then we did an online survey, which was developed for policymakers and aimed to explore the availability of maternal and child nutrition guidelines and policies that support identifying nutritionally at-risk infants, mothers, and pregnant women. We used Google Forms for the survey, which contained questions on guideline availability and perceived sufficiency of those guidelines by policymakers. On screen is the target number of health workers and policymakers per country, which we were targeting. And one of the limitations of this study was that there was rather a low respondent rate, particularly of the online survey. The response rates in some cases were as low as 50% of the target. Next slide, please. So the findings of the study were basically grouped in the main categories of the MAMI framework, as you can see on your screen. Next slide.
Sí, class.
I'll start with the findings of the definitions of at-risk categories. So the reviewed documents across countries revealed a lack of comprehensive criteria for nutrition vulnerability compared to, for example, the recent WHO 2023 guidance. Could you just please click? Yeah, click. Yes. So in the green are the criteria that were found in the documents review of the 4 countries. So these were the criteria that we found to how they define or they identified at-risk infants. These were mostly frequently found to be infants with poor growth based on single anthropometry measures like weight for length, nutritional edema, MUAC, and weight for age were not included. And then there were those with poor birth outcomes, such as the preterms, the low birth weights, and the small for gestational age. These were quite well identified in most documents. And then only in some documents did we identify neurodevelopmental concerns, such as disabilities. I think it was only basically in 1 or 2 countries. And some also included feeding concerns. So as a category, an illness, like illness of the infant as a category, but this did not include hospitalization per se. So one of the main gaps is really the fact that none of the documents that we reviewed in all the countries identified infants with poor growth based on sequential measures as a risk category. And very few mentioned the maternal risk factors on identifying mothers at risk. That was a clear gap. Next slide, please. So in terms of defining at-risk mothers, it was really only in the Philippines where some guidance was given. So in 3 out of the 4 countries that we included, we did not find any documents that identified who the at-risk mothers were. In the Philippines, the identified mothers included mothers with depression, poor social circumstances, malnourished pregnant women, lactating women, and adolescent mothers. Next slide, please. The prevalence of at-risk infants is given as a percentage of the total population of the under 6 months in each country in the table that you can see on your screen. So as you can see, there's wide variability between countries, but the prevalence of stunting, wasting, and being underweight goes above 10% in many countries, so it's quite high. Low birth weight, as you can see, is also quite high, with the highest prevalence in the Philippines at 14%. Risk factors for poor infant growth across the countries included the very low rates of exclusive breastfeeding that were recorded in basically all 4 of the countries reviewed. Interesting enough, although many of the health professionals did not perceive this to be a problem. Other issues like low birth weight, small for gestational age, prematurity, so these are poor birth outcomes, were also cited as significant risk factors for poor growth and development. Teenage pregnancies also came up consistently, owing to the high rate of teenage pregnancies in the countries. In some countries, it ranged between 30 to 40% of all pregnancies were teenage pregnancies. So that was a significant risk factor. Next slide, please. In terms of screening and identification of the infants first, screening was mostly presented in the IMAM guidance. In 2 countries, we found that national guidelines on low birth weight and premature babies also covered some level of screening. But yeah, it was generally in the IMAM guidance. And it was generally by anthropometry. So anthropometry was the primary screening criterion for nutrition vulnerability in infants under 6 months. It was also mostly done at outpatient clinic level, whether through growth monitoring or immunization visits. Community screening was a particularly weak point in most countries. Here and there, it is reported, but it seemed to be done in pockets rather than, wide-scale coverage. At both outpatient and inpatient level, screening methods like clinical and physical examination and observance of breastfeeding problems were only sometimes mentioned by the health professionals. But this was not really documented in the document review, which just shows that it's not really in the guidelines. And then in terms of the mothers, very little information across the countries was documented about how at-risk mothers of infants are screened and identified. In just one country, we found a couple of risk factors. Screening for pregnant women by anthropometry was mentioned, for example, and screening for anemia and adolescent pregnancies were identified as well to be at-risk categories. Next slide, please. So moving on to management and starting with the under 6 months group. First, the infants. Across countries, guidelines for low birth weight, infants with wasting, and those with breastfeeding or feeding challenges were mostly available, actually. However, the policymakers reported that existing guidelines were either insufficient or outdated, or in some cases, they were not sure about their perceived content sufficiency. One example of content sufficiency or perhaps outdatedness was the fact that the wasting guidance from all 4 countries only includes inpatient management as inpatient management care and not outpatient care as recommended in the 2013 WHO guidance for wasting. Then obviously now with the WHO 2023 guidance, there needs to be more updates. The reported gaps by the health workers in the management of infants under 6 months included those with disabilities. So that was reported consistently as a gap in guidance. And also the guidance on prematurity, only 2 countries had some form of guidance on this. A major gap was the enforcement and implementation of the BMS code, which proved to be a serious challenge in some countries, particularly with the online marketing of breast milk substitutes to mothers and social media use. There was also reported gaps in community-based management. Most care for infants was inpatient care. Next slide, please. So I move on to the management of women. As I mentioned before, at-risk pregnant women were not initially included in the document review, but we didn't capture any of the availability of guidelines for here. But health workers did touch on the perception of the management of at-risk pregnant women, which was mostly through iron and folic acid supplementation. And in some countries, there was patchy coverage of nutritional supplements and dietary counseling for pregnant women. In 3 countries, at the time of the study data collection, there was ongoing operational research on the use of multiple micronutrient supplements. That's something to note. And then the management of mothers was perceived to be particularly weak, as there was little mention of them in guidance, as I said, and except for the IMAM guidance, some IMAM guidances, which outline some broad statements on psychosocial care, for example, of mothers or nutrition supplementation for lactating women, there was very little mention of how to deal with mothers of infants at risk. So the identified gaps or the reported gaps by the health professionals were how to identify at-risk pregnant women in the first place, and then the management of mothers at risk in general, and having adolescent-friendly antenatal services given the high rates of teenage pregnancies in some countries. Yes, next slide, please. So in terms of follow-up and linkages to other programs, guidelines generally do not provide sufficient information on the follow-up of under 6 months infants and their mothers on discharge from either inpatient or outpatient treatment. In countries where follow-up activity was reported, and that's just in 2 really, it was done by community health workers generally. And there was a general feeling that the training could be enhanced to better follow up and provide more support in areas like breastfeeding support. Other issues like the lack of resources, equipment, and material to implement follow-up guidelines were also reported. Other issues like staff time allocated to community outreach and follow-up were also reported to be a challenge. Linkages to other programs were generally identified through NGO-supported programs, whose coverage was limited. But in some cases, there were livelihood support programs, for example, and breastfeeding support. Next slide, please. So the main challenges that were reported by the policymakers across 4 countries were the lack of finances to adequately identify and manage at-risk infants and women, reports of lack of equipment and materials, and too few human resources were given, as well as funding for research that could guide policy development or policy direction. The capacity building of health professionals was also a challenge that was reported, particularly the community health workers, who could be key to following up these at-risk groups. And policymakers also felt that the infants, this group or the groups of infants at risk and their mothers have not received the political commitment needed for them to become a priority. Next slide, please. So in terms of recommendations across the countries, more policy attention to prioritizing at-risk infants and their mothers. As discussed previously, there were gaps in policy for both groups that need to be addressed. Another recommendation is to update the existing guidance, such as the wasting guidance, and to develop new guidance in key areas like disabilities and prematurity that need to be done. So in terms of updates to existing guidance, it could start with adopting a more comprehensive criteria for identifying at-risk infants and women, strengthening adolescent girls' health and nutrition services, and providing adolescent-friendly antenatal care, strengthening the antenatal care package, and maternal nutrition, as we know that these are important risk factors for poor growth and development in infants beginning in utero. So across the 4 countries, the capacities of healthcare workers to identify, manage, and follow up on at-risk infants could and women rather, could be strengthened in specific areas, as I mentioned, like feeding difficulties and prematurity, and identifying women with adverse social circumstances like depression. Next slide, please. And then other areas to strengthen are the maternal nutrition programs, focusing on increasing access to affordable, healthy diets and quality antenatal care, especially for their adolescents, and considering introducing multiple micronutrient supplements based on the evidence of the ongoing operational research, and better integrating health and social services, such as the social safety programs, and strengthening the enforcement of the BMS code, particularly closing the loopholes in online marketing and social media marketing, for example. The frequency of data collection and including infants at risk and women of reproductive age in national survey research needs to be a priority. So in some cases, data available was over 10 years old, and we just don't have the prevalence information for some of the at-risk categories. So data collection must be strengthened and monitoring. Then finally, the continuum of care and the linkages between different levels of healthcare and services need to be strengthened. And this can be done by cross-referencing between guidelines and referral pathways across levels of care, for example. And one example of this rather is the link between hospital care and community care that could be closed. And with that, next slide, please. I would like to thank you for listening to me, and yeah, please welcome any questions that you may have. Thank you.